You're listening to Medscape's in-discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and a clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to Season 3 of Medscape Type 2 Diabetes podcast series. Today we'll be discussing incorporating screening and management of metabolic dysfunction-associated fatty liver disease in endocrine practice. First, let me introduce my guest, Dr. Isaacs. Scott Isaacs, MD, is a board-certified endocrinologist, obesity medicine specialist, chief medical officer at Atlanta Endocrine Associates, and associate professor of medicine at Emory University. Dr. Isaacs, welcome to Medscape in Discussion Type 2 Diabetes podcast.
Thank you for having me. I'm glad to be here.
Well, it's great to be working with you again, Scott. This is a podcast about type 2 diabetes. Why are we talking about MASLD?
Well, the discussion about MASLD, or metabolic dysfunction-associated steatotic liver disease, is really important in the diabetes podcast because MASLD is considered the hepatic complication of type 2 diabetes. In fact, sometimes we even refer to MASLD as diabetic hepatopathy. And type 2 diabetes is the most important risk factor for MASLD, and the metabolic disturbances underlying diabetes significantly contribute to the development and progression of liver disease. So it's important to view MASLD within the context of type 2 diabetes to gain insights into the comprehensive management strategies required to address both conditions effectively.
Well, could you go a little bit deeper into that and explain the relationship between insulin resistance, type 2 diabetes, and the development of MASLD?
Insulin resistance and lipotoxicity play a central role in the pathogenesis of both type 2 diabetes and steatotic liver disease. And this occurs when cells and muscles and fat in the liver don't respond to insulin and can't take up glucose from the blood. As a result, there's increased insulin production or hyperinsulinism. And over time, there can be insulin resistance, and this can lead to type 2 diabetes. So in the liver, insulin resistance impairs suppression of hepatic glucose production and enhances lipolysis. And this leads to increased free fatty acids in the bloodstream. And these free fatty acids are taken up by the liver and by fat cells, and this leads to lipotoxicity. And this sets the stage for MASLD, which can further progress to inflammation or metabolic dysfunction-associated steatohepatitis, which is where inflammation and the liver cell injury can occur with ongoing steatosis.
It's my understanding that oftentimes MASLD precedes the diagnosis of type 2 diabetes. You want to comment on that?
Yes. So because these conditions are associated with insulin resistance, that's the true underlying cause that sometimes we see steatotic liver disease in the pre-diabetes setting or even with obesity. But because all these underlying factors are going on at the same time with insulin resistance and lipotoxicity, these are all sort of concurrent conditions, comorbidities, or now what we call multimorbidities. And it's kind of like a bad marriage that the insulin resistance makes liver disease worse and liver disease makes insulin resistance worse.
So I understand from several presentations that one of the biggest risks that occur in patients with MASLD is actually not cirrhosis, but cardiovascular disease. How does MASLD impact that cardiovascular risk profile?
Well, that is exactly right, that there's this connection between the liver and the heart. And patients with MASLD are at very high risk for cardiovascular disease due to overlapping metabolic risk factors. So in addition to diabetes, obesity, hypertension, and dyslipidemia. And this inflammatory milieu and oxidative stress in MASLD exacerbates endothelial dysfunction and promotes development of atherogenic plaques. In addition, patients with MASLD have elevated levels of pro-inflammatory cytokines and adipokines such as TNF-alpha and IL-6, which can contribute to cardiovascular risk.
That's great information. Thank you for that. So let's move the discussion a little bit more on the discussion of diagnosing and management of MASLD in patients with type 2 diabetes.
So diagnosing and managing MASLD in patients with type 2 diabetes involves several nuanced differences compared to those without diabetes. But the main thing is it's important to point out that we're not trying to diagnose liver fat. We're screening for advanced liver fibrosis. And this is because as many as 70 to 80% of patients with type 2 diabetes have hepatic steatosis. But we want to find the patients that have liver fibrosis. And with type 2 diabetes, we know that that's about 20%, or 1 in 5 patients with type 2 diabetes have liver fibrosis. So that's a very high percentage compared to patients without diabetes. So it's important to screen for advanced liver fibrosis. And the first test that we use is called the FIB-4. And the FIB-4 is a mathematical equation that uses the AST, the ALT, the platelet count, and the patient's age to give a numerical score. And there are online calculators that you can use to calculate the FIB-4. But the point is that a FIB-4 score that's less than 1.3 is considered low risk for advanced liver fibrosis, where a score of over 1.3 indicates the need for further evaluation. And a FIB-4 score above 2.6 is considered high risk for advanced liver fibrosis, and these patients are typically referred to the liver specialist. So after the FIB-4, the next step would be an imaging test like elastography or a blood-based non-invasive test such as the ELF test, which stands for Enhanced Liver Fibrosis. And either of these tests are recommended as tools to screen for hepatic fibrosis. So the management strategies also diverge significantly in patients with type 2 diabetes because obviously controlling blood sugar is paramount. And so this often involves a careful selection of diabetes medications that don't exacerbate liver conditions, and also careful monitoring of liver enzymes, and selecting diabetes medications that may actually be beneficial for MASLD, which we'll get into a little bit later on in this podcast. And of course, we can't forget about lifestyle, and that's a very important part of the treatment program for patients with diabetes and steatotic liver disease.
I'd like to get back to the screening tools that you do. How often do you recommend that a FIB-4 be done?
Well, that's a great question because it's essentially a free test. You're using labs that are probably already being done. The guidelines recommend every 2 to 3 years, but I recommend doing it at least once a year because it's pretty easy to do and it's inexpensive. So that's a pretty good screening test that we can do in our patients with diabetes.
Well, thank you for that. That's really helpful to know because that's been a question that I've had in my mind trying to figure out how often I should be doing this. And by the way, for those of you on Epic, it is available. You can build into your Epic FIB-4, and I just have a dot phrase that puts it in, and it automatically comes into my chart. So you can look forward to asking your IT folks to get that available for you if you have Epic.
That's great. I'm very jealous. We don't have that technology in our EMR, but I know that it's available with Epic.
Yeah, it's really helpful because otherwise it's, pick up the phone or go online, and it just takes that extra amount of time that sometimes we just don't have. So you talked a little bit about the lifestyle interventions. Could you go into a little bit more detail of how you counsel your patients about diet and exercise and its impact on MASLD?
Sure. So lifestyle interventions are extremely important as part of the treatment of MASLD and MASH in patients with type 2 diabetes because we know that lifestyle can significantly impact disease progression and overall metabolic health. And so for patients that are overweight, weight loss is paramount. And so we recommend achieving weight loss of at least 5 to 10%, which can lead to substantial improvements in liver enzymes, liver histology, and insulin sensitivity. And weight loss has a dose-dependent effect. So losing 5% of weight can lead to a reduction in liver steatosis. 7% weight loss can lead to a reduction in inflammation, but it really takes a weight loss of 10% or more to see a reduction in liver fibrosis. So Dietary changes are very important, and I recommend a low-calorie balanced diet, such as the Mediterranean diet, which has data showing that it's helpful for MASLD, and especially noting that with the Mediterranean diet, it's low in sugar, low in saturated fat, and high in fruits and vegetables and whole grains and lean proteins. And we know that the Mediterranean diet, especially when it's a low-calorie version, can help reduce liver fat, it can improve glycemic control, and it can reduce cardiovascular risk. It's very important to have this focus on diet, but also physical activity is very important. And we know when it comes to hepatic steatosis that physical activity, even without weight loss, can have beneficial effects on liver fat. But we recommend the standard amount of physical activity, which is a minimum of 150 minutes of moderate intensity physical activity per week, with a goal of up to 300 minutes per week. Also, recommend behavioral therapy, such as counseling or group support to help maintain lifestyle changes. And this helps to set realistic goals, self-monitoring, and also just seeking support from healthcare professionals or other groups. So I think that having all these things together and having a constant focus on the lifestyle is always in the background for all of the other treatments that we use for MASLD.
Well, let's move on to the medical management. So, can you talk about medication choices that you might consider for patients who have type 2 diabetes and MASLD?
Yeah, so the management of patients that have both type 2 diabetes and MASLD requires a multifaceted approach, particularly with making medication choices that could be beneficial in improving both conditions. And the good news is that we know that certain diabetes medications have shown to be beneficial in improving MASLD. So first, I would start with GLP-1 receptor agonists like semaglutide and the dual agonists like tirzepatide. These medications have demonstrated significant benefits in reducing liver fat content and improving liver histology in patients with MASH. And obviously, they also provide excellent glycemic control. They promote weight loss along with reducing cardiovascular risk. So this combination makes the GLP-1 class of drugs an excellent choice for managing concurrent type 2 diabetes and MASLD.
So I just wanted to expand upon, GLP-1s are not all built the same. There are those that are stronger with A1C reduction, ones that are stronger with weight reduction. So you pointed out semaglutide as being your GLP-1 kind of choice. And I just want to emphasize to the audience the fact that the other GLP-1s, whereas they may be helpful for glucose control, may not confer enough weight loss to be beneficial in this setting, and I just wanna get your insight into that.
Well, I think that's an excellent point because we look at the mechanism of action of GLP-1 medications, and it appears to be all through weight loss. There are essentially no GLP-1 receptors on hepatocytes or on other cells in the liver. And so we know that they're not acting directly in the liver. So it appears to be an indirect effect through weight loss. And so it is proportionate to the amount of weight loss. And so obviously semaglutide has more weight loss than other GLP-1 agonists. But what I would also say is that we have the clinical data to show that GLP-1 medications like semaglutide have benefit. Histologic data showing reductions in liver fat and fibrosis. And the same goes with tirzepatide. So although we don't have a head-to-head study between the two with regards to liver health, both of these medications have published data on reduction in liver fibrosis, which is really what we're ultimately looking for.
That's great. What about the SGLT2 inhibitors? There have been some data with those. What is your insight into that?
Yeah, so SGLT2 inhibitors such as empagliflozin and dapagliflozin, they are beneficial in reducing liver fat. And we even have some non-invasive data showing that they reduce liver stiffness. But we don't have any histology data yet on the SGLT2 inhibitors. So we know they're helpful. They aid in obviously glycemic control, in weight loss, and cardiovascular reduction, and kidney health. And so they aid in all of those concurrent cardiometabolic issues that patients with MASLD and type 2 diabetes have. So they are considered a preferred medication. And it'd be nice one day if we can get some histology data, but we just don't have that yet.
But their impact on cardiovascular health, given the risk of cardiovascular disease and MASL, I think is a strong point in their favor in using those perhaps after the GLP-1s if you need additional treatment for that.
Yes, absolutely. Because we know, again, that these patients are at very high risk for cardiovascular disease.
So, how about the emerging therapies for MASH? Do you want to give the audience a insight as what's out there and perhaps a little idea about how you're using them in your practice?
Sure. Well, the first emerging therapy, I would say, is actually a therapy that has emerged, and that's resmetirom. And so, resmetirom is the first medication that is approved for the treatment of MASH. Resmetirom is a thyroid hormone beta receptor agonist. And so, this was recently approved for the treatment of MASH with F2 or F3 fibrosis. So, fibrosis is scored 0 through 4. 4 is cirrhosis. Whereas Resmetirom is really approved for treating sort of that mid-range fibrosis, not too mild and not too severe. The agent works on the thyroid hormone beta receptor, which is predominantly in the liver, and it works to improve lipid metabolism, reduce liver fat, decrease inflammation and fibrosis. And so this is an oral medication given once a day that has been shown to be effective and is approved by the FDA. And so there's more studies ongoing with this medication and other conditions in cirrhosis in the pediatric population. And there are other thyroid mimetics that are also under investigation. So this is the first class of drugs, new class of drugs that we have for MASLD. Another medication that I'd mention as an emerging drug, but it's really an oldie but a goodie, is pioglitazone, but also the PPAR class in general. So pioglitazone actually has pretty good histology data showing that it's beneficial for MASLD, but we also have an emerging therapy of a pan-PPAR agonist that works on alpha, beta, and gamma PPAR receptors called lanfibranor. Lanfibranor has had some promising results. It has some similar concerns to pioglitazone with weight gain, but it doesn't seem to cause weight gain when combined with other medications that cause weight loss, like the SGLT2 inhibitors or GLP-1 receptors. So we'll just have to wait and see what happens in the approval process with lanfibranor, but it's looking promising.
What about in working with your hepatologist? How do you collaborate with them in managing your patients with advanced MASH and type 2 diabetes?
Well, the partnership with a hepatologist is super important because there are so many patients with MASLD. There's just not enough hepatologists to manage all these patients. And so we need to have a structure in place for which patients are referred to the hepatologist and which patients are managed by the primary care physician and by the endocrinologist. So typically, we're going to use one of the treatment algorithms, such as the ACE algorithm or the AASLD algorithm, to risk stratify our patients with type 2 diabetes. And again, starting with that FIB4 score. And then using secondary tests such as elastography or non-invasive blood tests such as the ELF test to then further stratify our patients. And those patients that are at high risk, those that have a FIB4 score above 1.3, or especially those above 2.6, those would be the types of patients that would be referred to the hepatologist for management of advanced fibrosis, but also for screening for liver cancer. So it's important to know that patients with fibrosis are at significant risk for hepatocellular carcinoma, and they need to be screened every 6 months with ultrasound and with alpha fetoprotein. And so this is something that the hepatologist will do. But all of these patients also need management for cardiovascular risk. And that's where it comes back to the endocrinologist and the primary care doctor, because ultimately that can be the greatest cause of mortality in a lot of these patients. So it truly is this partnership between the hepatologist and the internist as far as managing all the aspects of patients with MASLD.
I just wanted to give you a call out. Dr. Isaacs was involved in writing the guidelines that were published by ACE a couple of years ago, which I think really opened a lot of our eyes into the importance of this subject in our endocrine practices. So do you have any final comments in terms of future research directions you think are critical for us understanding MASL and MASH?
I mean, there's a lot of research going on. I think the two biggest areas are going to be diagnosis and treatment. So we want to avoid liver biopsies whenever we can, invasive tests. And so we want better non-invasive tests. And, I mentioned a few with elastography and the FIB4. There's others with MRI-based technologies, but we still don't have the perfect way of diagnosing MASLD, of assessing a liver fibrosis. So that is one area. And then the second is new medications. I mentioned a few. There's other GLP-based medications that are also looking really exciting. But it's this concerted effort in clinical practice and research in a multidisciplinary approach with the PCPs, endocrinologists, and liver specialists that's essential to advancing the understanding and management of MASLD, especially in the context of type 2 diabetes.
Scott, I want to thank you for a very interesting and informative conversation today. So today we've talked to Dr. Scott Isaacs about the importance of screening for MASLD, including the testing, lifestyle management, and appropriate medication adjustments for patients with type 2 diabetes and MASLD. I want to thank the audience for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on type 2 diabetes. This is Dr. Carol Wysham for Medscape in Discussion Type 2 Diabetes podcast.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.